Okay, so today on our agenda, we will be focusing on reviewing the alternative payment model standards and implementation guidance, discussing the alternative payment models or defining alternative payment models and developing adoption goals. And we just have these two agenda items. We're hoping to spend a fair amount of time on both of them today to really get your feedback and get your discussion. And I think in addition to introducing yourselves today in the chat, also wanted to recognize we have a few new OHCA team members who are doing this today, including Debbie Lindis, who is our new senior primary care specialist who will be supporting the primary care investment workstream. So we're excited to have her join the team right as we will be turning to primary care investment shortly. So welcome you all to introduce and chat in the chat. And then, so just a quick reminder of our format. Again, we really appreciate all the discussion and comments in the chat. We use those after the meeting to debrief and adjust and use all of your feedback for how we are moving forward. So please feel to make comments and ask questions there. And of course, raise your hand as well. So in addition to introducing yourself in the chat, I wanted to introduce some of our new work group members. So we have Rhonda Chabran, and Rhonda, please correct me if I've introduced or pronounce your name wrong, who is the Director of Behavioral Health Quality and Regulatory Service for Kaiser Foundation Health Plan, who will fill our remaining health plan seats for the work group. And so please join me in welcoming Rhonda to the group. And Rhonda, if you wouldn't mind introducing yourself.
Thank you. I'm hoping my camera and mic are working. At first it said they were disabled. So can you hear me?
Yeah.
Awesome. So I just had a title change. I put it in the chat. Very happy to be here, and I'm excited to learn about the great work you all are doing.
Great. Thank you so much. We're excited to have you.
Thank you.
Okay. And so with that, we wanted to kick off our discussion today with a timeline update for alternative payment model adoption and also for primary care spend. And so just a quick kind of refresher of where we are in terms of our alternative payment model adoption work, our APM work. So in today's meeting, of course, we're focused on alternative payment models, draft standards, and then talking about definitions and getting to goals. And then we'll bring draft standards and definitions back to you next month for continued discussion based on feedback today, and also any feedback you have afterwards when we send out more details in follow-up emails. And then we will bring everything based on these two meetings, September and October, to the November advisory committee for discussion. And then following that advisory committee, we'll incorporate the advisory committee's feedback and come back to you for continued discussion and debrief on their feedback. And then leading up to March, bringing in March to the board the APM adoption, the APM standards, definitions, and adoption goals. And we'll also open up for a more formal public comment period at that time as well. Again, coming back and debriefing with the work group in May, and then bringing what we hope will be final APM standards, definition, and goals for board approval in June. So that's a reminder of our timeline and how we're hoping to debrief in the work group and use the advisory committee and board to solicit additional comments. And then for primary care, we are hoping to turn to, or we plan to turn to primary care in November. And, you know, we are eager to start the work on primary care, and I know some of you are too. So we will actually be launching a subgroup that will meet a few times And we welcome all of your participation in the subgroup if you'd like. And so I'll discuss more details on that in the next slide. So workgroup meetings from November through February will focus on primary care investment. And our goal is to bring early drafts of the primary care definition and investment target to the advisory committee for input in March. And then, of course, we'll work with you to debrief and adjust based on their feedback, and then refine and bring everything to the board for board feedback and public comment in May. And then again, debrief in the advisory committee in July, and then bring the primary care investment benchmark to the board for approval in July as well. And for those who are interested, as I mentioned, we will be launching a brief subgroup to begin work on the more technical aspects of the primary care investment work. We're planning for this subgroup to meet twice, once Wednesday, November 1st, and again on Wednesday, December 6th, to discuss topics such as like, what are the taxonomy codes that define primary care? What are the claims codes that define primary care? And this subgroup will dig into those details and then bring recommendations to the full work group for discussion. Everyone's invited to join the work group. We, again, just really wanted to keep this keep primary care moving forward. But of course, your attendance is not required. And if you are interested, please just email me and we will include you on the meeting invites and share all the meeting materials. And of course, we will come back to the work group to debrief and share what we've been working on in that subgroup. So I will pause here for any questions on the timeline or the primary care subgroup. Okay, if there are no questions, then we will turn to our next agenda item, which is to discuss the draft alternative payment model standards and implementation guidance. So I think, as we've talked about before, but kind of a refresher of our essentially our 3 work streams related to alternative payment model adoption. The first is to develop the alternative payment model standards, and the standards really aim to serve as best practices to guide healthcare entities in developing contracting terms that promote equitable, high quality, cost efficient care. And the next work stream is developing the definitions of alternative payment models. So these definitions, serve as a framework and the descriptions for the criteria for these types of payment arrangements that the payment arrangements must meet to count towards alternative payment model adoption goals. And then, of course, our last work stream is developing those alternative payment model adoption goals to promote meaningful adoption. And again, our overall goal of more equitable, high quality, cost efficient care. So as a refresher, I know you have seen this slide probably a few times by now, but essentially our goal under the statutory guidelines is to move more payments from fee-for-service to alternative payment models. And so this slide just again highlights the language related to standards in the bold type. So our statutory requirements in bold related to the standards. And then, of course, you've also seen this slide before, which provides more guidance on developing the alternative payment model contracting standards. So it specifies that the standards should facilitate multi-payer participation, alignment of measures, focus on protecting against unintended consequences, and aim to reduce administrative burden through alignment. And really, we see this as guidance, not to specify or define the standards, but to provide a set of principles that the standards should uphold. And again, last meeting we discussed using the OHCA statutory guidelines, we developed an objective and a set of criteria to guide the development of the standards. So we moved forward with using this objective and this set of criteria to develop the standards that we'll share with you in the next few slides. And before we get into the standards themselves, I wanted to share a little bit about the approach that the team took in developing the standards. So we felt it was really important to remain high level and strategic with the standards to enable them to be applicable and meaningful across payer types and populations and apply to different sectors. We also felt that it would be helpful to provide payers and providers and purchasers engaged in contracting with more specific guidance to support their efforts to implement the standards. So in addition to the standards themselves, we'll also be sharing an example of what we're calling implementation guidance that provides more detail, supplements the standards, provides specific actions that healthcare entities can take to meet the standard, and has examples as well. So the standards really focus on best practices, strategy, overall evidence, and the implementation guidance is supplemental and provides specific details and examples. So with all of that, the team developed this set of 8 standards based on national and California alternative payment model contracting lessons learned, and with the feedback of the work group over the last few months, and also some stakeholder interviews that we have been doing. So I will read through the 8 standards and I'll give you some time to digest, and then we'll go over the next 2 slides, and then we'll open it up for questions and feedback. So standard 1 is to use prospective budget-based quality linked payment models when possible. Standard 2 is to be transparent with providers in all aspects of payment model design and terms, including attribution and performance measurement. Standard 3 is to engage a wide range of providers by offering payment models that appeal to entities with varying capabilities and appetites for risk, including small independent practices. Standard 4 is to measure performance using a focused set of nationally standardized and locally adopted measures and technical specifications. Standard 5 is to collect demographic data, including real SOGI data, to enable stratifying performance. And we've defined real SOGI data as race, ethnicity, language, disability status, sex, sexual orientation, and gender identity. And 6 is to use data to address inequities in access and outcomes. 7 is to equip providers with actionable data to inform population health management and enable their success in the model. And 8 is to provide technical assistance to support new entrants and other providers in successful alternative payment model adoption. So I will move on to the next slide and walk through our next 2 slides. And again, we can come back to this slide if helpful. So this slide provides an example of the implementation guidance that I walked through earlier. So I will, I'll just give you a moment to read, and then also we can come back to this slide if helpful. But essentially, our approach is the standard is use prospective budget-based quality linked payment models, and then the implementation guidance underneath provides more details and examples. So 1.1 discusses paying providers in advance for a defined set of services to a population when possible, and mentions category 4A, 4B, and 4C. And then we also note that research finds that prospective payment of at least 60% of a provider organization's total payment results in meaningful change in clinical practice and reduces administrative burden. 1.2 notes that if category 4A is not feasible for a certain line of business or provider, that other advanced payment models should be used, including shared savings. And it mentions these as category 3A and 3B under the HCP land framework. And then implementation guidance 1.3 focuses on some examples. So designing core model components to align with models already in use, such as the MSSP program or the REACH program. And if full alignment is not possible, to look at how best to align and use lessons learned from CMS and others. So I will, sorry, I know we have a hand raised, but I will skip to this next slide and then we will open it up for questions just so we can get all the content here. So before opening it up for discussion, I just wanted to share what we have talked about internally and would like your feedback on is a vision of success for the alternative payment model standards. So potentially the first milestone is for stakeholders to endorse the standards. So for healthcare entities or purchasers or payers to commit to using the standards to inform future contracting. And we really see that the standards can only be successful if they're used and used broadly. And then our next milestone is that the standards result in more alignment across alternative payment models, and this alignment makes participation for providers easier. And then the last milestone is really about performance, that our overall goal is that performance improves, that we are improving outcomes, we're making healthcare more higher quality, more equitable, and more affordable. So this is kind of how we've laid out how the standards could work, how we could be, successful implementation of these standards would start with endorsement, greater participation in alternative payment models, leading to overall performance improving. So I will pause here for questions, and our key questions are really about, do these alternative payment model standards resonate? Are any major concepts missing? What do folks think about standards versus implementation guidance, and how could the implementation guidance best support stakeholders? And then how could we promote the broad use of standards? And I see two hands. Yes, I think Amy Nguyen Howell, welcome. And if you want to introduce yourself, and also, happy to answer questions.
Sure. Good morning, everyone. Amy Nguyen Howell. I lead the Office for Provider Advancement within Optum Health, and happy to be here. Thank you so much for the opportunity to contribute to this incredible committee, and it's nice to see familiar faces and old and still continued friends. So I've two quick questions, Margarita. If you could go back to the slide on the standards. One of my main questions is around, I keep hearing equitable care, and I appreciate number 5, the demographic data, the RAL-SOGI data. And what about 6? It says use data to address inequities. I'd like to capture between 5 and 6 specific, whether it's SDOH, social drivers, whatever we want to call it. But there needs to be specific purposeful, meaningful pulling of data, getting data from common tools like the Prepare tool. And I just want us to be purposeful about the specific data, the type of data, and to put it in the standards that it is part of the standard to procure this data, and not just have claims data per se, right? I just wanted the specificity of the type of data that we're getting so that we can get to the access and the outcomes for our patients and communities. And there are proven data tools that we can use that help us get there. And so I just kind of want to put that out to everyone, because it in in the work that I, do day to day, it is quite challenging. And until we can, as a state and as a country, to get there, we're just going to be pulling data from the air and from whatever we have, as opposed to having a systematic, systemic, rather meaningful and purposeful process about this. So that's one thing that I'd like to add. And I think it was on your other slide, your second question. I was going to add something if you don't mind showing that up so it can prompt me, because oh yeah, the implementation guidance. So my question was around, are there going to be incentives to implement these standards? I didn't see that in the timeline slide, the slide before this. So what happens when organizations say, "Oh, that's nice, that's great, but what's in it for me?" Like the so what?
Yeah, well, I think the OHCA
Yeah, so those are my
as an
two.
organization does not would not be providing incentives necessarily for meeting these standards. Really, what we are looking for is to drive more alignment across the market, to get folks to, work together, to collaborate, to have similar alternative payment models, to really enable, small independent practices to participate more in alternative payment models, other types of providers who may not be participating currently. And, so there are direct incentives. We're hoping we can build alignment and work together to implement these standards. Of course, with lots of feedback and adjustment to enable them to work for you all. And then I think what we can do is think about how to report on these standards and what progress we're making and how we are moving collectively towards, that overall goal of more high quality, equitable, cost efficient care, and how we're meeting the alternative payment model standards and goals. And we can definitely think about for standard 5 and standard 6 how to be more specific, provide more details in the implementation guidance or other ways, and we can definitely follow up and get into those more details. And I think Carrie, I saw your hand next. Sorry, I'm just going down the list.
Yes, hi Margarita. Thanks for this, and we'll have more detailed comments, but I did want to just point out a couple things. One is I appreciate Amy's addition of social determinants of health data. I think that's an important component of this model. So I just wanted to do a +1 on that. But I think the other thing that's a couple things that are missing for me. I think one is getting to more equitable care is not just about collecting demographic data, but also encouraging, enabling, and measuring the adoption of more person-centered, culturally and linguistically appropriate care. And I don't really see that reflected in these in the standards. I think we ideally are in an APM model are encouraging and driving care that's more culturally and linguistically appropriate, including whether it's through incorporation of a diverse and expanded healthcare workforce or interpretation, on-site interpretation services or whatever that looks like. But I think that really is important to call out. The other thing on standard 3, where you talk about engaging a wide range of providers, there's a discussion of providers with different capacities, including small and independent practices. But I think what's missing for me is also historically under-resourced providers. How are we thinking about the types of providers that just haven't got, that have been treating maybe a high volume of Medi-Cal patients and or are in areas that are just under-resourced and are not able to utilize other financing structures. I think we really need to be thinking about how we're building up a healthcare system that can really help everyone. And then lastly, on the technical assistance, I think technical assistance is great, but I think some providers, will also need financing, like upfront financing or payments to really support this transformative health system or healthcare that we'd like to see. So those are just some initial thoughts that I have, and I'd love to hear any reflections or reactions, but also I'll put this in writing as well.
Thank you, Carrie. Yes, I think just on the upfront financing, that was part of our rationale or thought behind the focus on number 1 of prospective budget-based quality linked payment models. That prospective piece can help provide that upfront payment, but we can think about how to either be more clear or include more specifics throughout. And again, for 5 and 6, in terms of actually using the data to address inequities, including culturally competent care, we can think about ways to incorporate that or make that more clear as well. And I think you had one other point, but maybe we'll just go on to Catherine and then Joe, and then also see if other folks have suggestions or comments.
Sure. Thanks, Margaretta. Catherine Phillips from the California Healthcare Foundation. A response on your first question, I think broadly speaking, the standards do resonate, so thank you. My question was, you often see called out a commitment to risk adjustment, both an attempt to measure patient acuity and social needs. I didn't see that here, at least in the bold font, high level top bill, and was curious if that was intentionally excluded, if it's something you plan to offer plans a lot of latitude on, or if it's embedded somewhere else.
Yeah, I think we were thinking it was part of number 2, but yeah, Mary Jo, do you want to speak to that?
Sure, I can just note that it is included as one of the draft implementation guidance pieces. And so we will be circulating the full draft implementation guidance following this meeting, but it is included there.
Okay,
and
thank
if
you.
you'd like, I'm happy to read it. It just says, utilize risk adjustment methodologies that incorporate clinical diagnoses, demographic factors, and other relevant information, monitor emerging methodologies to incorporate social determinants of health, and explore opportunities to integrate them.
Thank you.
And Joe, go ahead.
Thank you. Yeah, Joe Castiglione, Blue Shield of California. I think overall, very supportive of the standards that you've laid out here. Certainly some comments that maybe they're best saved for the benchmarking part or the benchmarking and reporting part of this discussion. So I'll mention we can defer if it makes sense. I think overall very much support the move toward understanding that we as a health plan cannot currently any self-funded, any ASO lives into category 4. So that we may have a misunderstanding area, but that is our current interpretation of what the legal environment does provide. So I just want to highlight here, I think it is certainly a bigger issue for other plans than it is for Blue Shield of California. But when we think about measuring our overall spend through alternative payment models, and particularly the standards that you've laid out here, which do incorporate or do encourage population-based payment, just want to highlight that we may not be able to do that currently in an ASO environment. And we welcome any guidance to suggest otherwise, but I do want to flag that for the office as you sort of think about trying to drive alignment across business lines. The other thing that I would mention here is really just kind of a nomenclature issue or consideration, rather. It's not so much an issue, but the use of the word providers versus clinicians, a big sort of goal for us as a plan in driving these payment models is to reduce individual clinician burnout. And so thinking about whether we're talking about providers, which can of course refer to a large system versus a clinician, which actually it's like, I think a lot of the intent behind this alignment work is to actually get clinicians to be able to spend more time with patients, focus more on quality, for example. So just want to consider, propose that for the group to consider whether it makes more sense to discuss this in the context of clinicians versus providers. And then the last piece here is definitely support the inclusion of small and independent and rural practices, under-resourced practices, or historically under-resourced practices. I think I heard mentioned a short while ago. I just want to highlight too that these, I think, are sometimes the practices that often have the least engagement in value-based payment models, and those are the practices for which multi-payer alignment is really the most critical. And so when you think about the office's role, highlighting or in any way supporting active and ongoing multi-payer alignment efforts that focus on adoption of specific payment models. You all know, or a lot of you know, we're involved in the Advanced Primary Care Initiative, California APC initiative. Anything like that where you can actually highlight and encourage or facilitate those types of work groups or work streams, I think would be helpful, specifically for inclusion of these small, independent, and historically under-resourced practices.
Thank you, Joe. Yeah, really helpful. And we can think more about the clinician piece. And if folks have suggestions or thoughts on that, please chime in. And Cindy.
Can you hear me?
Yes.
Okay, so my comment is just the same as it's always been, is that we have DHCS over here doing an alternative payment model for Medi-Cal managed care. And then we have this effort going on. And I just want to make sure that when we're looking at metrics for measuring performance and the data that we're going to collect, that we're coordinating and not creating extra work for providers who may be doing both.
Yes, that is one of our kind of core efforts every time we look at measuring performance. So, and I will just note in this, in our more detailed implementation guidance, we specifically note like aligning with state purchasers, including DHCS. We also, in our, other work across the office, we will again be looking to align on any measures we use with other state purchasers as well. So yes, thank you. And Lisa.
Thank you. So I know the APM standards are inclusive of specialty care and primary care, and that the criteria that you reviewed specifically talks about appealing to a wide range of providers. And research shows, and I think there's a general understanding, that in order to bend the cost curve, create a more equitable system, and achieve the other goals of APMs, that we really need to incent primary care in a way that we don't in our current fee-for-service system, but that's not specifically called out in the standards. And so it feels like if that is one of our goals, do we want to make sure that that's very specific in those standards so that we don't lose sight of that?
Yes, that's definitely something we considered, and we include, I forget where, but in our draft implementation guidance that we'll share with you shortly, primary care providers are highlighted, but would welcome, others' feedback on, how to better do that and how to better emphasize that. And,
it doesn't feel like it's just about the primary care clinician, but really sort of incenting a more preventative primary care approach, which feels foundational to any APM. And that's why it felt to me that it was really missing from the standards, if that's our guiding light.
Yes, Bill.
Thanks. Hey, how closely do you intend to track the Learning Action Network model in this process?
And maybe expand on that a little bit? What do you, yeah, what?
Well, the
You wanna
Learning
add?
Action Network, the LAN, was formed several years ago. Amy Wynn Howell worked on that quite a bit for us when she was with APG. There are four levels, 4 degrees of APM payment that are recognized at the national level. And I just wondered, are we paying attention to that? Are we following it? Are we doing something different? I'm just a little confused here about where we're headed.
Yes, so we are definitely, I will just maybe move to our next, the implementation guidance. So we definitely plan to use the HCP land framework as kind of our guiding structure for alternative payment model adoption. So both within, the implementation guidance, and then also I know we talked about, a slightly different framework for data collection, but we're still planning to roll up any data on APM adoption into those HCP land categories. So we have, a way we can compare nationally. And Joe.
Sorry, yeah, just one more comment that came up on the last slide. I know that there was a lot of discussion here about driving equity through the use of APMs. It looks like it's primarily, the conversation is really focusing around the collection, the use of data to support equity through APMs. Is there going to be an expectation around the use of payment differentials to drive equity through APMs as well? And is that going to be a part of the standards? And I ask because, again, we may be misinterpreting, I don't know, but it is our current understanding that we may not be able to pay differentially based on certain member demographic data. So I just want to call that out here and see if I'm missing a piece, or if payment and incentives is not necessarily going to be one of the standards through which we'd use or drive equity through the use of APMs.
So I think, Joe, if I'm interpreting correctly, it would be paying different providers differently based on their population or their population demographics, or?
Yeah. So for example, we had a payment model where we were paying differentially for care gap closures based on certain member demographic data. So that may just be the specific design of the model that we use that we were unfortunately told we could no longer use. So I'm just trying to get a sense of whether there is going to be an expectation that incentives do need to be tied to some specific piece of data in order to support or to meet the standards that you're laying out here. And I ask that because I actually don't see anything in here that specifically says paying differentially to help drive equity. It looks mostly around the use of data. So I just want to clarify that piece here. And I'm sorry if I'm not being clear.
No, I think I'm tracking. So we had not specified anything tied to differential payment based on demographic factors in the standards or our draft implementation guidance. Welcome feedback, thoughts on that as well. And Kevin.
Thanks. I wanted to follow up on both Joe's and Lisa's comments. I very much agree with Joe, and I see there's been some comments in the chat about risk adjustment methodologies, but I do think if we're going to really say how can APM approaches promote equity, that is probably the strongest mechanism to do so, is to actually give more resources to those practices and organizations caring for patients with higher social needs. Frankly, those are much bigger influences over sort of healthcare resources needed than traditional diagnostic case mix based HCC type coding approaches. And that would be the real bold step forward for California, to actually say that would be a standard we should promote. It does have the implications that, for example, you get paid more to take care of patients who have Medi-Cal than you do for patients who have commercial insurance. But that actually is how many other nations are doing it, and using more geographic-based risk adjustment based on census characteristics of very small areas, which can't be gamed. and it doesn't rely on collecting social, history data, SDH data. It's very much on things like the demographic makeup of a census block, which is easily done through geocoding. So I would like to second Joe's comment and actually formally propose that that be included as a standard, that there should be a consideration of adjusting payments for social need. The second one is I'd also like to kind of more formally pick up on Lisa's comment, is there is inherent in going from a fee-for-service to prospective payment models, particularly the Land 4, but even the Land 3 that require attribution. That attribution and that prospective payment is driven by the selection of a primary care clinician and medical group, right? I mean, it's all hinges on that. So it's sort of, again, implicit in alternate payment models is that it's all then built on a foundation of primary care, because that actually is what drives the flow of the money, as well as how care ideally is being sort of organized. So I do think that would need to be part of the standards, just like we have network, standards for capacity standards under the Office of Managed Health, Department of Managed Healthcare. I mean, I think somewhere in the standard has to be assurance that there's adequacy of the primary care network capacity and sufficient resourcing of that to allow an APM to actually function well in the delivery of care. So those are two, that's a bit long-winded, but I wonder if there's a way, Margareta, to go back from just comments to like formal proposals to make from this group about including a standard about social need, risk-adjusted payment considerations, and sort of network adequacy and sufficient resourcing of primary care as part of the standard for APMs.
Thank you, Kevin. Yeah, I mean, if folks want to chime in the chat, or otherwise, I know we got some seconds from Bill and Paula and Adam. So if others, want to chime in about those two pieces, please do. And Janice.
Sorry, I was having trouble unmuting. Janice Rocco with the California Medical Association, and I very much agree with those last statements. What we're doing here is exactly what we're charged with doing, and yet I keep having in the back of my mind that without the access piece, it's all sort of a bit cart before the horse. We can't achieve some of these things without actually making sure that patients have timely access to care, and so as was just talked about. In terms of the draft standards, this has been a very helpful discussion, and I think that what we have here is certainly on the right track, headed in the right direction. It does occur to me that when we get later in the slides and we start talking about the specific measurable goals, that we would then revisit the standards to make sure that once there's an agreement on what those measurable goals are, that these standards sort of drive towards whatever the decisions are that are made there. And then Margareta, you had mentioned the implementation guidance, and it also occurs to me that the stakeholder review process related to that will be key in making sure that we've got everything in there that we need for folks to know what they're supposed to be doing.
Definitely. Yes, that's a really good flag. Yeah, that these kind of the three pieces, the standards, the definitions, and the goals are intended to work together and, drive towards our overall outcome. So we will definitely, think about how to make sure that they're all working together as we move forward. Yes, and just a reminder that we will send probably not today, but hopefully either by the end of this week or early next week, the draft standards plus implementation guidance via email to you all for written comments and more detailed feedback. And would welcome you to share that with others in your organization for feedback. So I think I'm not seeing any other hand raised or pieces in the chat. Again, if you have from the two areas that Kevin flagged based on our feedback in terms of payment based on social risk or demographic factors, please add that in the chat, and then also notes around how to kind of emphasize the role of primary care providers in the APMs. Welcome additional feedback there and otherwise. And I think to keep us moving, I will turn to our next agenda item. And again, we can always come back with more specifics in our next meeting based on all of your feedback we receive in writing. So I'll turn it over to Mary Jo and Dolores to walk us through this next section on defining APMs and developing adoption goals.
Thank you, Margaretta. All right, let's go to our first slide. So to begin, this slide provides some information on national APM adoption from the Healthcare Payment Learning and Action Network, or the HCP-LAN, which was referenced just a few moments ago. As you may remember, the HCP-LAN is a collaboration of the Centers for Medicare and Medicaid Services and several national payers who've essentially come together to define and measure and guide APM adoption nationally. And I know that many of you have been involved in that effort in various roles. So appreciate that. The HCP-LAN assigns payment models to categories based on a variety of factors, but mostly their structure and their terms, and essentially how much risk is being assumed by the provider organization. It also measures, so uses those categories to measure APM adoption and then sets goals for adoption. On this slide, we're really focused on HCP-LAN Category 3 and Category 4. Category 3 payments are those payment models that are built on a fee-for-service architecture, but have an opportunity for providers to share in savings generated when care is less costly than expected. Depending on the arrangement, providers may also be expected to pay money back if care is more costly than expected. So those models where providers have to pay money back are referred to as Category 3, often referred to as downside risk models. Models without this downside risk to the provider fall under Category 3A. So 3B for those where there is downside risk, 3A where there is not that downside risk to the provider. And then up top there, you see Category 4 payments, and those are typically various types of capitation payments. So on this slide, this is data from 2021, which was the most recent available from the HCP-LAN. I believe 2022 will be coming out soon. As shown on this slide, national APM adoption varied based on the payer type, with less than about 35% of commercial payments flowing through categories 3 and 4, compared to about 57% of Medicare Advantage payments flowing through these categories. All right, let's go to the next slide. So my slide didn't forward, but I don't know if others did.
Are you seeing the framework, Mary Jo, or no?
I'm not, but maybe others are.
I'm also not seeing the framework.
Oh, okay. Let me try resharing. It
No
looks
problem.
fine on my end.
Perfect, thank you.
Oh, okay.
Yes, that's great. So here is the framework that we referenced on the previous slide. Just a reminder, and I know that this was in the chat a few moments ago as well, that OHCA plans to collect data using what we're calling the expanded framework, and there's more information on that again in the appendix. and then crosswalk to the HCP land. So as I mentioned, latest draft of the expanded framework is provided in the appendix. We have shared that with you previously, and it will come back. But also just noting here that we would crosswalk that data to HCP land and use HCP land for those adoption goals. I wanted to note that in this version of the HCP land graphic, we've put in color categories 3 and 4. And this is because APM adoption goals typically focus on those categories. So adoption typically measured by either the spend that is flowing through a contract with an APM, the members attributed to APMs, or providers contracted under APMs. So next, I'm going to turn it over to Dolores Yangahara of the Integrated Healthcare Association to discuss APM adoption in California. Dolores, we're really grateful to her. She provides some excellent subject matter expertise to the FHC team. So turning it over to Dolores.
Great. Thank you, Mary Jo, and good morning, everyone. The data that we'll be discussing in the next slides was collected by IHA and is available via our Atlas web tool. And I'll start with the commercial APM adoption. Data collected by IHA represents about 88% of the commercial fully insured market. And on the next slide, excuse me, we'll discuss the impact of Kaiser Permanente within the fully insured market. The self-insured data is excluded here. So commercial APM adoption by enrollment in California in 2021 differed greatly between HMO POS and PPO EPO arrangements. HMO POS adoption in 2021 was almost entirely associated with Category 4, generally capitation arrangements, representing about 9.5 million people, compared to only about 100,000 people associated with Category 1 and 2. In contrast, Category 1 and 2 arrangements make up the majority of the PPO-EPO arrangements, with about 2.4 million members associated with Category 1 and 2, and only around 440,000 members associated with Category 3. When looking at the entire fully insured market in 2021, these opposites even out a bit, and we see 77% of members associated with Category 4 arrangements, so about 9.5 million people, 20% of members associated with Category 1 and 2 arrangements, or about 2.5 million people, and then only 3% of members associated with Category 3 arrangements, which is about 440,000 people. Next slide, please. So APM adoption in the fully insured commercial market in California over the past 5 years has remained pretty stable. While we see a jump in the percentage of enrollment associated with Category 4 from 70% in 2017 to 77% in 2018, the percentage since then has remained steady through 2021 in Category 4. We also see some slight growth in the percentage of enrollment associated with Category 3 between 2017 and 2018 from 2 to 3%, and then again between 2020 and 2021 from 3 to 4%. While this data is based on membership, we also measured adoption in terms of dollars, and we saw similar results for that. Two things to note about this data is that over 50% of the total population is enrolled with Kaiser Permanente, with over 6 million people enrolled with Kaiser Permanente each year between 2017 and 2021. And then one limitation of the data is that we do not have precise numbers on how much of the Category 4 enrollment is in arrangements tied to quality. We do know that all of the plans that IHA has data for participate in IHA's Align, Measure, Perform, or AMP program, which measures, reports, and provides incentives based partly on quality performance. Next slide, please. All right, turning to the 2021 Medicare market share by enrollment, Based on data from the Kaiser Family Foundation, we see that just under half, or 47% of California's Medicare beneficiaries participated in traditional Medicare, and that leaves about 53% of the enrollment tied to a Medicare Advantage plan. Next slide, please. Before we jump into this slide, I would like to note that we did update the numbers and figures on this slide after the materials were sent out to the workgroup members to include Kaiser Permanente Medicare Advantage beneficiaries to be consistent with our approach for calculating the commercial numbers on the prior slides. So when we focus on APM adoption by Medicare Advantage beneficiaries for California for 2021, we see that a strong majority, 98% of beneficiaries, are enrolled in a Category 4 arrangement, and only 2% are enrolled in Category 1 and 2 arrangements. This includes beneficiaries enrolled with Kaiser Permanente, and Kaiser Permanente accounts for over 60% of Medicare Advantage enrollment in California in 2021 for the data that IHA has. Now that we have described the current state of APM adoption in California in different market types, I will turn it back over to Mary Jo to begin discussing achieving goals in APM adoption.
Thank you. All right, let's go to the next slide. And here we just wanted to give you a little bit of a deeper dive into the Medicare Shared Savings Program. So in traditional Medicare, the most common APM arrangement is the Medicare Shared Savings Program, which is sometimes referred to as MSSP. Nationally, CMS has found the program has produced modest savings. Savings have been greater for beneficiaries who are assigned to ACOs that are referred to as low revenue. That's often referring to ACOs that are led by physician organizations, as compared to beneficiaries assigned to ACOs with physicians and hospitals as members, which are often referred to as high revenue ACOs. So for example, in 2022, high revenue ACOs generated only about $140 per capita net savings. So that's after the performance payments were given back to the providers, versus $228 in net savings for low revenue ACOs. So those ACOs typically led by physician organizations. That difference jumped to $294 in per capita net savings when the ACO had 75% or more primary care physicians. So really sort of emphasizing the important role of primary care in generating strong outcomes in value-based care. ACOs participating in MSSP also had higher average performance on reported quality measures than similarly sized clinician groups that did not participate in MSSP. So MSSP did seem to lead to better quality results. I will note that if you look at this table, the 2022 MSSP data is really new. So in this table, we're actually looking at 2021 results, but can update this if it's helpful. Basically, similar to the national, the number and percentage of California low revenue ACOs earning shared savings was higher than the number and percentage of high revenue ACOs earning shared savings. So similar to national, low revenue performed better than high revenue. All right, let's go ahead to the next slide.
Mary Jo, sorry, there's a question in the chat just about the definition of low and high revenue. Would you mind just repeating that again?
Absolutely. So the low revenue typically refers to physician-led ACOs. Essentially, the organization has to be receiving 35% or less of the Part A and B revenues to be considered low revenue. If the organization is receiving in and of itself more than 35% of Part A and B revenues, then it is a high revenue ACO. Does that help answer the question?
Okay. And then Kevin, do you have a quick question, or should, can we come back?
it's fine to come back. So
Okay.
I'll put my hand down and then just
Thank
come back to me. Yeah.
Will do. Go ahead.
All right, let's go ahead to slide 26. So CMS has a big goal for APM adoption. It is expecting 100% of all Medicare beneficiaries in traditional Medicare and Medicare Advantage to be in a category 3B or category 4 APM by 2030. And for traditional Medicare, it focuses on two primary programs for providers to choose from. So the first is MSSP, which we talked about and gave results for just a few minutes ago. Essentially, this is Medicare's largest alternative payment model program. It includes several tracks to offer provider organizations varying degrees of risk depending on their experience and capacity. MSSP tracks qualify as HCP land category 3A or 3B, depending on the track. So some include downside risks, some do not. I'll say that growth in this program has stalled in recent years, and CMS has several changes on the way for 2024, many of which are aimed at making MSSP more attractive to providers. The other program, Realizing Equity, Access, and Community Health, this program is replacing the relatively short-lived CMS direct contracting program. Providers can choose a professional risk or a global risk track. So these models are classified as HCP land category 4. This model really aims to have a strong focus on health equity, and similar to MSSP, several changes on the way for 2024. All right, let's go ahead to the next slide. Okay, so with this background on national goals and programs, we wanted to shift to a discussion of APM definitions and adoption goals in California. This slide may look familiar to you. It shows the same statutory language as we shared earlier today and that we've shared in the past, but this version of the slide has content related to statewide goals or benchmarks in bold type. So if we go to the next slide, we wanted to start with talking a little bit about the role of definitions in the process. So an early step in developing APM adoption goals is defining what types of APMs will count as an APM for purposes of the goal. So definitions may require payment models meet certain conditions related to the model design or the level of risk sharing to be included towards adoption goals. And we're going to walk through some examples in just a couple of minutes. I think what's important to highlight here, though, is that definitions can go beyond requiring APMs be classified in a specific category, such as 3 or 4. They can include language to help ensure that APMs align with the contracting standards and support quality and affordability and equity. So I think a few minutes ago, someone asked, well, can we sort of go back and look at all of this as a whole at the end? And that is exactly what we intend to do, and to really think about how each one of these pieces supports each other. If we go to the next slide, we wanted to just sort of give you an overview of what are the key decisions that OHCA will be seeking your input on today related to APM definitions and goals. So the first set is really related to those definitions. So to count towards the goal, should the definition require alignment with certain programs? Or should the APM be required to include a tie to quality of performance? Should the APM be required to have a certain level of risk sharing? So, similar to MSSP, should OHCA allow risk sharing, that level of risk sharing to vary by type of provider? Under MSSP, those low revenue ACOs don't have to take on as much risk and sort of can do it on a different pace than high revenue ACOs to make those models more attractive to low revenue providers. And then last on this side, to count towards the goal, should APMs be required to include a certain amount of prospective payment? And then on the other side of the slide here, we have a few questions for your consideration related to goals. So which HCP land categories should be included? And should goals vary by payer type or by product type, like HMO, for example? And then what unit of measurement, members, dollars, providers, should the goals be based on? And how should the goals be structured? All right, so if we go to the next slide, we will show some examples. These are state and national APM adoption definitions and how essentially were different states have defined what counts towards various goals. So for example, in Delaware, the state found that there was low provider participation in commercial APMs. And when they talked with stakeholders, the stakeholders said that, too often the APMs did not offer sufficient meaningful upside and or insufficient shared risk for providers. And so the state decided that since it had high adoption of Medicare MSSP, it would essentially require that commercial APMs move more towards MSSP. So essentially, in terms to count towards their APM adoption requirements, those models had to align with MSSP in terms of risk sharing and corridors and other design features. HCP land, for example, does not allow risk-based payments not linked to quality. So those are defined as 3N and 4N to be considered advanced APMs, and therefore they do not count towards APM goals. So we have to have a link to quality under HCP land. And then in recognition of the better results that are often posted by physician-led or low revenue ACOs, and also those ACOs' general greater reluctance to take on risk, Rhode Island allows payment models to require less risk sharing for low revenue or physician-led ACOs than high revenue, which are typically health system-led ACOs. A similar allowance is made in Delaware as well. And then in Oregon, they really wanted to ensure that sufficient dollars were being paid to and paid prospectively to support primary care. So it has required its managed care organizations, its Medicaid coordinated care organizations, they're called, to fund primary care medical home clinics with prospective revenue. All right, let's go to the next slide. Here we're going to shift just a little bit. We wanted to show you what the national HCP land adoption goals look like by year and by payer. So as we dive into more of a conversation on goals, note that under HCP land, payment models must be category 3B, so with that downside risk, or category 4A, B, or C, so those prospective, more capitation-like arrangements to qualify towards the goal. And as mentioned on the previous slide, category 4N payments and category 3N payments, which do not have that tie to quality, do not count toward the HCP land adoption goal. All right, so just a couple more slides before we pause for some discussion. So here on slide 33, wanted to give you some examples of APM adoption goals in California. Several of the state's public purchasers, so Covered California, CalPERS, and Department of Healthcare Services, are requiring contractors to expand the percent of primary care physicians who are paid through HCP land categories 3 and 4. Covered California also has a series of stair-step goals in place, and by 2025, it will require contractors have at least 70% of primary care providers contracted under a category 3 or 4 APM to avoid a penalty. Department of Healthcare Services has a specific goal associated with the percent of enrollees assigned to public hospitals who receive care under an APM, so that's 60%. All right, let's go to slide 32. This slide seeks your input on various design decisions that OHCA will need to make as it develops APM adoption goals and examples of decisions made by others. So as mentioned earlier, most APM adoption goals focus on category 3 and category 4. Other important questions include, should goals vary by payer or product type? And what unit of measurement should be used as the basis for the goals? So important to note, OHCA statute requires adoption goals are based on the percent spend tied to an APM or the percent members attributed to APMs. And that could really be an and or if you wanted. Goals based on other units of measurement would be in addition to the percent spend and or percent membership goals. All right, so wanted to, on the next slide, give you some examples of how goals might be structured. So the first example here is a stair-step goal, which essentially sets a defined goal that increases over time. So for example, 50% of all payments to healthcare providers should be tied to an APM by 2026. And this percentage should increase to 60% by 2027 and 70% by 2028. That's sort of an example of a stair-step goal. The next is an absolute improvement goal. So that sets a specific defined goal for the future, but it tends to rely on a single number and often puts the goal several years into the future. This approach can feel more aspirational, but it also makes it difficult sometimes to hold entities accountable for intermediate progress. And then the last is a relative improvement goal, which does not put forward a specific defined goal for all, but rather asks each entity to increase APM adoption from their current starting point by a defined amount, so maybe 10% annually. This can be helpful in the early years of goals where there is less information to inform a target, especially about specific populations. It's important to note that all of these approaches to goals can be layered or combined. So for example, one approach might be to set an absolute improvement goal for a few years into the future, and then pair it with an annual relative improvement goal. All right, and so with that, we're going to switch over to some discussion. And I will turn it back over to Margaretta to moderate the discussion.
Thank you, Mary Jo. And I know Kevin had his hand raised, so we'll probably go to Kevin first. But our key questions for discussion are, should the APM adoption goals focus on those advanced APMs, generally categories 3 and 4, so those population-based payment models, models with shared savings and shared risk? And then what are the trade-offs of basing goals on percent spend tied to APMs compared to percent members attributed to APMs? And then should the goals vary by payer type, commercial, Medicare, Medi-Cal, or by product type and or by product type, HMO versus PPO? And then what are some trade-offs of the different types of goals or the different approaches to goals, stair-step, absolute improvement, relative improvement? So those are lots of key questions, and welcome all feedback, and we'll start with Kevin.
Thanks, Margaret, and thanks for the presentations. I think my comment here is going to focus on the first item here. And I hate to make life complicated for us, but the whole land category 3 and category 4 becomes a real mess in California when you're dealing with our whole ecosystem of managed care. So, the data you show, wow, if you're in an HMO, all those are land 4, right? By definition. But, network HMOs are funny entities and, they're just, it tells you nothing about the incentives actually for the people delivering care to know that you're in a network model HMO. It's one thing to have Kaiser there, which globally budgets its hospitals and has, a salaried, capitated medical group. But once you get into the network HMOs, many of them pay hospitals still on a per diem or DRG basis. It's no different from a traditional, non-HMO plan. They may capitate a medical group or IPA that may then pay their physician constituents on fee for service. I was struck when I was vice president of population health for a while at UCSF Health System, and suddenly we had the commercial HMO saying, let's set up ACOs. I'm saying, why do you need an ACO if you already have an HMO, right? What's the point of that? And it became clear that it was because, there was no, it was an HMO, but it was still so traditionally oriented in terms of the incentives about the payment models that they really didn't feel different from a land, even land two. So I think this is going to be very tricky, because if you just say, well, we'll move everybody, or, more people in network HMOs, I'm not sure it actually changes things that much, and that, in fact, many of them are using payment models that are much more land category 3 when you actually look under the hood and see how they're compensating their provider organizations. So I don't know if then I actually can say what I mean by the implications of all of this, but I just think we need to be aware it's much more complicated than sort of these tidy categories and where people think in. And I think we need to maybe step back a little bit and just say, it's back to those principles, Margareta, you shared at first. Like, what are we really trying to accomplish with these alternative payment models? And how do we provide some guidance? Because I think it's just a little too easy to brand things as, land 4, land 3, and it may actually not be telling us what we really need to know about moving into payment models that are really trying to move towards a more population equity focused, quality focused way of delivering care.
Yes, that's definitely a key challenge. And Mary Jo, did you want to chime in?
Well, I was just wondering if we can think about ways to use the definitions to support creating categories that feel more meaningful. So I don't know if we can maybe just go back a couple of slides to the definitions for a second, because I think that is a leverage point that's important to consider. So, for example, you could say that in order for, and I'm just saying this could be said, you could say that in order for a category 4 payment to count as category 4, it has to have a tie to quality. It has to have some sort of downstream impact on, provider payment. It can't just be sort of at the network level. So I would just ask the group to consider whether or not the definitions are a vehicle to drive more meaningful adoption.
And looks like Catherine, your hand is raised next.
Yes, but I was going to go to questions 2 and 4. So do you want to see if there's any others on this one before I pull us down?
Any thoughts from folks on the advanced APMs? Bill or Joe or others?
Well, I just wanted to remind everybody that we have years and years of data in the Atlas that compare network HMO requirements against PPO networks in terms of measured quality, performance, lower overall cost, total cost of care, and lower overall out-of-pocket spending. Some of the metrics that are used for quality performance are also being used by the DMHC as proxies on equity. I'm frustrated that we don't really pay much attention to the Atlas results to inform our policy in California.
So I think, so maybe Bill, that there's just, there is an understanding or general evidence that points that the HMO model in California is, provides higher quality, lower cost care. But then I think our key is how do we enhance that and make sure that's consistent across, all markets, across all payers. So yeah, I think that is definitely clear to us, but it's how do we kind of standardize that and make it more prevalent?
Well, I agree with you. I think the problem here is that that market only serves 2.7 million Californians at the present time. I mean, there was a time when it served 10 million Californians, but if you take Kaiser Permanente out of the mix, the rest of the network HMO first dollar coverage market in California really only serves about 2.7 million people at this time out of 40 million. The 6 million lives that are in self-funded, for example, can't take advantage of that market to a great degree because of Knox-Keene Act prohibitions. So, I mean, I think that's one of the policy objectives here. How are you going, if you are going to make a concerted effort to duplicate that performance across other elements of the market, what are the barriers that are preventing you from doing that?
Right. Yeah, I know we've talked on and off a lot about that. So I think we can think about ways to work that into our efforts or make that clear where, what we're talking about when in terms of markets. Joe, sorry, I'm just going to try to keep us moving with only a few minutes left.
Sure, yeah, I'm aware that we are close to time, so I'm just going to try to rapid fire a couple pieces of feedback here. Yes, it's definitely supportive of the ties to quality, just going back to that slide where you had the sort of different options laid out. Yes, very much supportive of the new entrance model that you mentioned from Oregon that drives investment in primary care clinicians. I think that pretty closely ties to the other set of work that this group is going to be doing, so I just want to call that out. Unsure about the alignment with CMS. I think in general, our response would be yes, but for example, the Medicare Shared Savings Program currently doesn't align or facilitate hybrid payment to individual primary care clinicians. So again, partial capitation or partial population-based payments, and partial fee for service. That's not currently allowed in the MSSP environment, or there's a proposal for it to be, but currently it is not. So again, in general, yes, supportive of alignment with CMS models and programs, but the devil, I think, is really in the details on that. Definitely strongly believe that it should be % of spend rather than % of membership. We have lots of members that don't see a provider in a given year, so the denominator on a membership benchmark, I think, may be a little bit trickier to design, although I think we'd certainly be open to discussion about how to do that. And then the final piece is just around the percentage of providers. I think in general, we'd be against a benchmark that's based on amount of percentage of providers. There are a lot of barriers here that I think have been raised throughout this discussion. In particular, the small and independent practices who are not currently equipped to transition to any type of population-based payment model. If we can get multi-payer alignment and get some of that work really up and running a little bit faster than it is currently, I think it does make more sense, but currently there are many practices who are just not equipped, and then certain specialties may never make sense for alternative payment model. Like, does it make sense for a podiatrist to be in an APM? I'm not sure, right? So again, I think a lot of this just points back to, for us currently, given the current limitations in the current environment, strongly believe that it should be % of spend. And I'll cut my comments off there.
Thank you, Joe. And Catherine, I'll go to you next, since we've dug into questions, I think 3 and 4 you were mentioning.
Sure, I have thoughts on the % members versus % spend. I will type those up and share them because I know we're short on time, and jump to question 4. I'd put a vote for stair-step improvement. I think that's the simplest. It's the cleanest. It allows room for structured, informed growth over time. And so of those 3 options would put my vote in for that. There's example precedent merit in all 3 options, but I think for the reasons discussed, stair-step makes the most sense, at least to start.
Thank you. And it looks like maybe Amy, you had your hand up.
Oh, I did. I just wanted to be cognizant of time and share the floor with everyone. So I think just maybe two comments that I'll make is I agree with everything that everyone said around primary care, and I just wanted to make note and put it out there that we shouldn't ignore and maybe put a little bit more emphasis on specialty care. They do come up to about 60% of the cost. And when you're looking at the quadruple aim and we're all faced with affordability financial headwinds in the next 3 years, given the final notice. And I know that this is just the Medicare product line. However, it affects everyone's bottom line in the organizations that we serve. So I would like to see or maybe encourage the focus or more focus on specialty care as well, while obviously remaining true and faithful to the primary care efforts. And then with respect, I'm in the type of product type, if you're going to answer all these questions, because it's really what the consumer, what the patient, what the member sees, and if we're truly patient-centric in our decisions, in our service to our patients, our members, perhaps we could reimagine how we approach this and approach it in a product type. And I agree with the statement before in terms of stair step. I just ask the work group and the folks here, how fast do we want to accelerate? How fast do we want to move? Because sometimes stair step doesn't allow us for that. But if we don't have the ability to move fast, given resources, then stair step is appropriate.
So I think with our minute left, and of course, folks, please chime in the chat, and also, of course, we'll follow up via email, both with the draft standards and implementation guidance for your more detailed written feedback, and then welcome written comments on these key questions that we walked through in the last half of the meeting on definitions and goals. So we are hoping, throughout, September, early October, that we'll get your feedback on the draft standards and implementation guidance. We will then work on revising those and getting them back to you in October, continue to work on the draft definitions and goals, and then have another more detailed discussion on definitions and goals in October. And then go to the advisory committee in November with standards, definitions, and goals for their feedback. So thank you all for an amazing discussion today. Again, please feel free to email and add more feedback that way, and we will also capture everything you've shared in the chat. So thank you, everyone, and we'll talk to you soon.